Good afternoon. Dean Finnegan, graduates, distinguished guests, faculty, students, staff, family members, and friends. It's a great privilege to be able to congratulate you and celebrate with you today. My public health career began when I was around 7 years old. We were living in Guatemala, where my father was the founding director of INCAP, a nutrition research institution for the Pan American Health Organization. He would put us kids in a Jeep, and off we'd go to villages with names like Santa Maria Cauqué or San Antonio Aguascalientes. And my job was to help line the children up so my father could check them for goiter or malnutrition. I would reassure them, it's okay, he's my dad, he won't hurt you. But at the same time, Dad would say, look at this little boy, he has second-degree malnutrition, and he would tell me how that had come about. We moved back to the U.S. when I was 16, but I've never gotten over being Guatemalan in many ways, and that determined that my work would be with the Latino and African-American communities. I rebelled against my physician father in college by going into anthropology instead of medicine, but I couldn't forget those children. And I couldn't stay away from public health. I became a medical anthropologist and worked in a village in Bolivia, and then Barbados and Spanish Harlem in New York, Haiti, Colombia, Ecuador, South Central Los Angeles, Chicago. And supporting public health students and colleagues around the world has taken me through most of Latin America and several countries in Africa, Asia, and the Middle East. My passion all these years has been access to health care and prevention, cultural differences in perceptions of health and illness, and barriers to care and communication. I realize now that I was working on correcting health disparities, on health equity, and on social determinants of health long before any of us used those words. Today, I'll share with you lessons from many years of work to improve health. What's happened in that time? What have we learned as a profession and as a cluster of disciplines? What has changed and what is the same? What would I do differently, knowing what we know now? And what advice would I give to you, today's graduates? So lesson 1, it's about behavior. And I'm not just saying this because I'm an anthropologist. When I began working in public health, we worried most about infectious diseases and unwanted pregnancies. Just examples, but that sort of thing. And in both cases, there were those who believed that a single magic bullet would solve everything. Both oral contraceptives and measles vaccine became available a few years before I started college, and they exemplified this approach. Give women all over the world a pill, vaccinate all the babies, and everything would be fine. Well, more than 40 years later, we eradicated smallpox, but we still see measles and other preventable infectious diseases, and women still have unwanted pregnancies. Only now, we also have diseases like HIV/AIDS, Ebola, and the Zika virus, infectious diseases whose transmission can only be prevented through behavioral precautions. We also now have convincing evidence of the impact of behavior on biology through a growing literature on the health effects of stress, including stress stemming from racism and from exposure to violence and conflict. We face obesity in epidemic proportions, along with an increase in type 2 diabetes and other preventable chronic diseases. So one of the greatest public health challenges continues to be how to create and support behavior change. More people admit it's important today than in the past. Try being an anthropologist in a medical school 30 years ago. We have more theories, more interventions, and strategies. But behavior remains one of our greatest obstacles to health. And some of you in this graduating class will address this challenge, and you will advance solutions. Lesson 2. The world is more complicated than we think. Back in the 60s, we actually believed, and they were called vertical programs in those days, that focused on one problem at a time. Malaria, contraception, diarrheal disease, malnutrition. The problem is that malnutrition is made worse by diarrheal disease and malaria, and it's more likely in closely spaced children. So why are we looking at things one at a time? 15 years ago at the CDC, with the Task Force for Community Preventative Services, we developed a model for the sociocultural environment as a framework for health. This framework incorporates into determinants of health concepts like social justice, housing, environmental hazards, community cohesion, and access to education. Oh yes, access to health services is also there, but it's only one of 6 key proximate determinants. And since then, many, many models of the social determinants of health have emerged. And to quote Alvin Tartov, genes in biology and clinical care only determine 20% of health. The rest is social and economic factors, health behaviors, and physical environment. Close quote. So why does 80% of our health dollar go to medical services, which could be defined as sick care, not health care? How else can we explain that in Boston, life expectancy varies by as much as 33 years between neighborhoods that are only a couple of miles away from each other? Or that here in Minneapolis, St. Paul, people living 3 miles apart have a 13-year difference in life expectancy in the same city. A recent National Academy of Medicine report stresses the importance of understanding the social determinants of health in health professions education. Your challenge now is to incorporate the social determinants of health into public health practice in a world that will keep trying to simplify the problems and the solutions. Lesson 3, if you can't take the long view, you're wasting your time and your money. I'm convinced that the biggest challenge to the health of the public is a short-term view of funders and policymakers. This is caused by several factors. In particular, too few public dollars and too many demands on those scarce resources, and this is only getting worse. We also see disparities in the value that elected officials place on health as a public necessity, and disagreements on who bears the responsibility for health: the individual, the healthcare system, or the government, when in reality, it's all three to different degrees. When these issues are combined with the fact that many public health measures will make a difference after, not before, the next election, it's easy to see why it takes real courage and vision to enact such measures. And one of my heroes is a mayor in a Brazilian town who said that instead of building something he could put his name on, he built a new sewer system for his community. One of the problems faced by policymakers is that when public health measures succeed, nothing happens, or very little. Ebola and avian influenza do not become pandemic. Infants don't get tuberculosis from milk. It's difficult to justify spending money to prevent something that may not occur. When a public health problem does occur, it's often treated as a crisis, and more is spent on addressing it than it would have cost to prevent it in the first place. It's our job to say this again and again and again, with our data, with our testimony, and with our participation in policy making, again and again until we are heard. Lesson 4, diseases and people change faster than academicians and policymakers. Our public health world is rapidly and constantly changing. In the 1980s, HIV/AIDS changed the risks for many sexual behaviors and IV drug use. Today, we have threats like pandemic influenza, Ebola, and the Zika virus, just to name a few. We must be much, much more nimble than we are now. Our curricula need to change in months, not years. Our communication styles to the public need to speak to how people receive messages today, so the tweeting is a good thing, because this is changing constantly. We've missed our mark on communication around public health, and we need to quickly learn how to get it right. Think about the news today. How do we persuade Congress today to fund prevention measures for mosquito-borne diseases in the U.S.? Think about it. Zika virus, no funding. You graduate into a world where how to learn and how to react and change quickly are far more important than this is how we always do it. So be prepared for change. Whatever curriculum, program, or solution you develop, it will need to be different tomorrow. Lesson 5. People really do know what they want. We've finally begun to reach for and accept community wisdom. For many years, health planners assumed they knew what communities needed and how to do it. You know, here come the academics again. Here come the Ministry of Health people again. But now we know that our greatest chances of success are when we become true partners. So I think back to the story of some health workers in Guatemala who were working with the Bear Horse Clinic, who went to a community to try to do improvements in child health and in maternal and child health. They went to the community leaders first, who of course were men in that day. And the men said, oh no, this is women's business. Go talk to the women. So the group went and spoke to the women. And the women said, the group were smart enough, so they said, what do you need? And the women said, we want to learn how to crochet. And the health workers kind of went, huh? But one of them knew how to crochet. So she said, well, let's teach them. And then maybe we can get them talking. So they taught the women how to crochet. Why did the women want to learn how to crochet? They needed the money. They needed to be able to make things they could sell, and they needed the money to buy food for their children, which would improve their children's health. And as a matter of fact, when you crochet, your hands are busy, but your mind, your mouth, your eyes, your ears are free, and you can talk about health. So the community knew what they needed. My colleagues, Nadine Peacock, Marcelina Morgan, and I partnered with community activist Loretta Jones in South Central Los Angeles in the early 1900s on the first CDC-funded community participatory research project. Today, community participatory research is transforming relationships between researchers, health departments, practitioners, students, and communities. So remember to listen to the community. Lesson 6, be generous. You're graduating today with master's and doctoral degrees that put you in a rarefied group of people lucky enough to have advanced degrees. Around the world, education is a precious commodity. Even a little education is associated with better health and, of course, a better standard of living. So share your wealth. And I'm not talking about your money right now, although I hope eventually when you can, you'll contribute to give back for scholarships for the students who follow you. But I mean the wealth of your knowledge, the wealth of your position, and your privilege. Be a mentor and watch a young professional bloom. Use your skills to educate a community. Share ideas liberally. Give your time to students who want a few minutes with you, to a community leader who has a case to make, to a coworker with an idea. Reach back from your position of privilege to bring others along. Lesson 7, be a leader, follow your gut, and act with passion. Leadership is hard, it's fun, it's lonely, it's exhilarating, and it's never dull. You are graduating into a profession where you will all need to be leaders. Leadership includes the ability to listen to a wide variety of creative, strongly held, and often contradictory ideas, and come up with a plan that everyone can embrace or at least live with. Leadership means speaking up. Leadership means being inclusive and respectful of others. And as your dean said, and I wrote this before I heard it, so we certainly agree, public health is a team sport. You can't do it alone. Perhaps most important, trust your gut, your instincts, and it took me years to learn that. Every now and then you will be wrong, but more often you'll be right and you'll be innovative. Many key innovations have emerged from wild ideas. Consult and listen when you get those ideas, but be bold as well, because no one ever led from behind. Passion helps. Passion is not only persuasive, it's often what generates those wild ideas and what carries you through the difficult times. And finally, what would I have done differently? Not waited so long to have a child and to try to have a second child. Stayed home with my daughter a little more when she was growing up. Gone back sooner to making choral singing part of my life. Maybe discovered kayaking and riding on the back of my husband's motorcycle a little sooner. Made more time to be with friends. In other words, I would have taken more time to play and to be with people I love. I share this with you as graduates because it's too bad to wait so many years to discover how important a balanced life is. Right now, getting a job or returning full-time to your current job, furthering your career, pursuing more education, saving the world, may all seem like the most important things in your life. These things are important, but take some time for yourselves and your families too. In public health, we try to teach people to balance their lives in healthy ways. So let's practice that ourselves as well. Goodbye, good luck, do good, and pass it on. Thank you.